Good morning, delegates, and welcome back. This is one of a very interesting session. This question usually we ask to PGs. What is the difference between AV dissociation and complete heart block, and what is the significance? This is the common question. Okay, and we have got a great person here to deliver lecture on this, Dr. Martin Green. I heard that Dr. Prabhakar was telling that I didn't know about Dr. Martin, but he told that he is known all over the world about this, particularly with the ECGs, and is a great quiz master. He is from University of Toronto. He has got many appointments and is working as assistant professor of medicine in cardiology in the University of Ottawa, Heart Institute, University of Ottawa, and associate professor of medicine in the Ottawa Heart Institute, and professor of medicine in the. So he has been from long way. He is there with the cardiology department, and I request him to go ahead with it. Over to Dr. Marty.
Thank you. It's a pleasure to be here. I was asked by Dr. Prabhakar to speak on AV dissociation and heart block. Are they the same? And the answer, I could simply do this, say yes and no, and then we'd be finished. But I think that really wouldn't be doing justice to a complicated electrical phenomenon. So we're going to talk a little bit about association and dissociation both, so we can get an idea of to what extent they are the same and to what extent they are different. So let's spend a moment on definitions, and there can sometimes be confusing. AV dissociation means that you have independent atrial and ventricular activation. So there is no relationship between P waves and QRS complexes. That's the simplest, but that of course can be seen both with tachycardias, ventricular tachycardia, and complete heart block, because they can both be totally dissociated. What gets confusing is the partial AV associations. So some non-one-to-one relationships where one drives the other. For instance, you can have ventricular tachycardia with 2-to-1 retrograde VA conduction. That is, the ventricle can drive the atrium, but it is not one-to-one. So they're partially associated. They're not dissociated. They're just non-one-to-one. So you can have it with more QRS complexes, such as with ventricular tachycardia, or with more P waves than QRSs, such as with atrial tachycardia with 3-to-2 or 2-to-1 conduction, or complete heart block, both of which will have more P waves than QRSs. One of them will be partially associated, and one of them will be totally dissociated. So it gets a little complicated because complete heart block will be completely dissociated, but 2-to-1 conduction is not dissociated. It's just partially associated. Heart block, also more P waves than QRSs, except, and I'm going to throw out first degree heart block because it probably shouldn't be called heart block. It's only a just prolonged conduction as opposed to heart block, because no P waves are blocked in first degree AV block. But second degree and third degree AV block both have block. In other words, they have more P waves than QRSs. And the last concept I want to talk to you about is conduction versus block. You'll notice that if I have an ECG with atrial tachycardia and 3-to-2 or 2-to-1 conduction, I will call it 3-to-2 conduction, not 3-to-2 block, or 2-to-1 conduction rather than 2-to-1 block. Why is that? Because block suggests a process which is pathologic or non-physiologic, whereas if you have a very fast atrial tachycardia, it is physiologic to not have one-to-one conduction. So we call those 3-to-2 or 2-to-1 conduction rather than 2-to-1 block. Okay, so second degree AV block, partial association. Some P waves are conducted, some not. Third degree AV block, no P waves are conducted. The two rhythms are totally independent, and they are completely dissociated. Okay. So let's start off with more V's than A's. VT, for instance. There may be a complex relationship. You may have VA conduction that is 1-to-1, or you may have VA conduction that is 2-to-1, or you may have V-A Wenckebach, or you may have sinus rhythm, which would be complete dissociation. But the other ones are associated, although not 1-to-1. This is not heart block, but it is AV dissociation when you have sinus rhythm in the atria. So here is a 85-year-old man who presented with palpitation, and you can see that this is VT, ventricular tachycardia. It's a wide complex tachycardia. There's a QR in lead V3 and QSs across the lateral precordium, indicative of a previous anterolateral infarction. And if you look closely, we look in V1, we can actually see sinus P waves. They are sinus, they're typical sinus P waves, which are completely dissociated from the ventricular tachycardia. In other words, the atria are in sinus rhythm. The ventricles are in ventricular tachycardia. This is complete AV dissociation, although it is clearly not complete heart block. This is AV dissociation. The ventricles are in VT. The atria are in sinus rhythm. You always have to ask yourself, what is the atrial rhythm, in order to determine whether we're going to call it dissociation or not. So here is a more complicated one, because this is partial AV association. We now see that there are fusion beats. Some beats that are conducted, meaning the atria are in sinus rhythm, but there's actually conduction. So you can't really call this AV dissociation. You can call it VA dissociation, but there is some AV conduction even during ventricular tachycardia. So there is VA dissociation, but partial AV association. Does that make sense? Now you see what I'm getting at as we get into all of these complex situations where there may be conduction, but they're not totally dissociated. So here's another ventricular tachycardia. Again, more V's than A's. It's important to recognize where the A's are, and you can see what the first thing you look for is a bump, and we look for it and we see that it has a high frequency, so it's probably a P wave. This is lead 2, it's probably a sinus P wave. And then, we can actually march those through and see other P waves, and we can prove that this is total AV dissociation. The ventricles are in VT, the atria are in sinus rhythm. Complete AV dissociation and complete VA dissociation. But here's an even more complex one. If we look carefully here, and I'm going to have to blow this up for you so you can see it. Look here. There's a negative P wave in lead 2. Negative, suggesting it is VA conducted. But look at the next beat. Also a negative P wave, but with a longer VA interval. And look at the next beat. Also VA conducted, but with a negative P wave, but with an even longer VA interval. And then look at the next beat. We've lost our P wave. That's the end of the T wave of the previous beat. There is no P wave. And then it repeats again with a P wave there, and then another V-A Wenckebach episode here. So this is ventriculo-atrial Wenckebach. VA conduction, 4-3 during ventricular tachycardia, with the fourth ventricle activation not being conducted to the atrium, and the VA interval progressively prolonging before the block. Look at that one more time. V to A, V to A, V to A even longer, and then this one not. So this is ventricular tachycardia, but this is not VA dissociated. There is in fact a complex V-A Wenckebach, but it is AV dissociated. Okay, let's keep going. Now, we've talked about dissociation and association with more V's than A's. Rarely we can get this with more A's than V's. So this is an elderly lady who presented with sinus rhythm at a rate of about 60-something, but 2 V's for each A. I think Dr. Vora was with us when we did this case. This is probably about 17 or 18 years ago, but I've saved this ECG. That's how unusual it is. So I'm going to blow up V1 for you, and what you see here is a sinus P wave followed by a V, followed by another V. More V's than A's, even though the atria are in sinus rhythm, but this obviously isn't ventricular tachycardia, so this is one of those rare situations where you have a 2-for-1 atrioventricular conduction. One sinus beat conducts down the fast pathway and the slow pathway simultaneously to give 2 V's. It's fairly unusual. 1-to-2 conduction. Now, we can also look at the situations where we have more A's than V's. Not all of these are heart block. Some of them are, some of them aren't. And what you have to ask is the atrial rhythm sinus or is it not sinus? That's what defines whether it's block versus normal physiology. Remember we talked about first degree AV block, where it's not really block at all. Second degree AV block, and we talk about Mobitz 1 Wenckebach type block with progressive PR prolongation, and then Mobitz 2 block with no prolongation prior to the dropped one. And we talked about third degree AV block where no P waves are conducted and the atria and ventricular rhythms are dissociated. So let's look at this. What is this? Is this heart block? If we look here in V1, we see A. So there's more A's than V's. The ventricular rhythm is irregular, so almost certainly there is conduction, but this is not heart block. This is atypical atrial flutter. It is normal not to have 1-to-1 AV conduction with a very fast atrial rhythm. So this is normal physiology for the AV node to block. So I would call this not heart block, but rather it's an atrial flutter, an atypical atrial flutter with variable AV conduction, not AV block, because this is physiologic. Again, we have atrial flutter. This is a typical atrial flutter this time. There are clearly more A's than V's, but there is conduction, in this case 4-to-1, 4 A's for each V. This is not block. I call this 4-to-1 conduction, not 4-to-1 block, because this is physiologic, not pathologic. Okay? But you have to be careful, because the way we tell that this, because the ventricular rhythm, unlike the previous one, the ventricular rhythm was irregular. This one, the ventricular rhythm is perfectly regular. So it's possible that I could have dissociated rhythms. The way I can tell that they're not dissociated is to examine the AV relationship. So if they are associated, then each flutter wave that precedes a QRS should have the same AV interval as the next one. So I look here, 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 I look here. They're the same. So I have a fast atrial rhythm, a slower ventricular rhythm, but the relationship is constant. Therefore, it must be 4-to-1 conduction, right? As opposed to dissociated rhythms. On the other hand, so is this, what is the rhythm? Atrial flutter, yes. Heart block, no. Let's do the next one. What is the rhythm? Again, the rhythm is atrial flutter, but is it heart block? So what do we have to do? It is atrial flutter for sure. We have to ask the question, what is the atrial rhythm separately from what is the ventricular rhythm? If you ask them together, it's too easy to think that this is the same as the previous one. Now I have atrial flutter in the atrium, and I have a regular ventricular rhythm. But when I look carefully, if I compare the flutter wave to the next QRS, it varies in interval. This one is a short one. This is a much longer one. This is intermediate. They vary. So if the atrial rhythm is regular and the ventricular rhythm is regular, but the two aren't together, they must be dissociated. In other words, these are two independent rhythms. This is heart block. This is atrial flutter with total, complete AV dissociation. It looks like a difficult one. It looks like it's harder than, but it's very simple. You just have to look at the relationship between the A and the V. If they are both regular, but the relationship is not constant, they must be dissociated. If they are both regular and the relationship is constant, they must be associated. So is this atrial flutter? Yes. Is this heart block? Yes. These two rhythms are completely dissociated. And I've blown that up here for you in lead 1, 2, and 3, and you can nicely see in lead 2 how the flutter waves and the QRSs do not have a constant relationship. So this is dissociated rhythms. You have to start off by looking at the atrial rhythm and deciding what is the atrial rhythm. You have to do that. So this one is non-sinus, the V's are regular, but there's an inconstant AV relationship, so these are dissociated rhythms. Now, if I look to this one, what is this? Well, I see a P wave halfway in between two QRS complexes. And I look here, whenever I see a P wave halfway in between, I have to ask, is there another one? And there's another one. But this is not a sinus P wave. Look in V1 and V2. So this is atrial tachycardia. Here it is blown up in lead 2 with 2-to-1 conduction. I would not call this 2-to-1 block. Understand the difference. This is 2-to-1 conduction because it is normal to have block in the AV node with a fast atrial rhythm. So this is atrial tachycardia, not sinus tachycardia. If we'd said it was sinus tachycardia, we would have called it block. But it's atrial tachycardia with 2-to-1 conduction. And you can see the second P wave, non-sinus atrial tachycardia, 2-to-1 conduction. Not all blocked P waves are heart block. So what we're trying to determine is it a physiologic or is it a non-physiologic phenomenon? So when I look at this and I blow up lead 2 and 3 again, I see that in between the pause, I see this atrial, I see a P wave here. But it looks different than the sinus P wave. It's negative. So this is a premature atrial contraction, and when I do the PP intervals, this is premature. So this is a blocked PAC, but this is not heart block. Because heart block, it would have to have been a blocked sinus beat. Okay. Blocked PACs. So heart block is abnormal conduction physiology. It can be very complex. It's important to differentiate proximal from distal block. Conduction patterns may be helpful, Wenckebach versus Mobitz 2, but if you think about it, 2-to-1 block becomes difficult now because I can't see the pattern of PR prolongation prior to the block. Typical Wenckebach block is usually proximal. Typical Mobitz 2 block is usually distal. But if you have 2-to-1, you can't tell because you don't have an opportunity to prolong the PR interval. Look for that, and we have to look for the company it keeps. Sometimes serious conduction disease can exist in the absence of heart block, and I give an example of alternating bundle branch block, but I won't go into that anymore because we're talking about dissociation and block. So what's the rhythm here? We see sinus rhythm, we see right bundle with some rightward axis, And here we see a P wave that's not conducted. And we look and we compare the PR interval of this beat to the PR interval of the next conducted beat, and it's the same. And we see no PR prolongation prior to the block, and this person clearly has distal conduction disease because he has right bundle branch block. So this is Mobitz 2 second degree AV block, distal AV block. Okay? Distal block. And there it is blown up. You can see the block P wave, and you can see the absence of prolongation prior to the block. Mobitz 2 distal block. Now, this is another example of distal block that's not so easy to diagnose. I have atrial fibrillation. What's the remember we always ask, what's the atrial rhythm? Well, what's the atrial rhythm here? Atrial fibrillation. So the atrial rhythm is atrial fibrillation, but the ventricular rhythm is regular. You shouldn't have a regular ventricular rhythm from an irregular input into the AV node. So this, indeed, dissociated. So this is complete block. Do I have another couple of minutes? Okay. There's first degree AV block, a prolonged PR interval. Second degree AV block, there's a Wenckebach. There's the Mobitz 2 with no prolongation and distal block, and there's complete AV block. But I want to spend a moment, if I can have 2 more minutes, on 2-to-1 block. Because 2-to-1 block is difficult, but it's still critically important to decide whether it's proximal or distal. So in this case, I have right bundle branch block, and I have left axis deviation, and I have 2-to-1 block. So this is almost, you have to look for the company it keeps. This is almost certainly distal block. Distal block. Here, the second P wave is seen at the end of this T wave, but this is an inferior infarct, a narrow QRS. So they're both 2-to-1 block, but the last one was distal. This is almost certainly proximal block, and there we can see the 2-to-1 block. This is block now, and it's proximal block, likely AV nodal. But sometimes it's difficult. Here's a 2-to-1 block. It's hard to see. I've showed this one yesterday, and there's the P wave at the end of the T wave. This is 2-to-1. It's a left bundle. It's probably distal block. Likely distal block. Here's one of the ones that'll get you. And there is a clue here. So here I see 2-to-1 conduction, 2-to-1 block, P wave. There's the second P wave. You can see it in the T wave here. 2-to-1 block. The QRS is wide-ish, but look, this PR interval of the conducted beat is very long. It's about 320 milliseconds. If you think about it, distal block should never have such a long PR interval because this delay would all have to be below the hiss, and you never see HV intervals of 200 and something. So this is probably proximal block, even though the QRS is wide-ish. And if you wait a little later on, this same patient ends up with 3-to-2 Wenckebach conduction, typical for proximal block, typical Wenckebach periodicity. And this one, again, with a right bundle branch block, has a long PR interval and an inferior infarct. So even though it's right bundle branch block, this is proximal block. This is AV nodal block. This will recover and does not require pacing. So not all blocks are AV block. You can have, this case, I'll just quickly, this is SA block. And we can see here it's slowed down. So this is actually 2-to-1, 1-to-1 with some occasional block beats, and ultimately 2-to-1 SA conduction. And there it is there. And lastly, the last ECG I'm going to show you is a complex block, not dissociated because we see that the QRSs are irregular, atrial flutter. And when I count out the P waves, I see that the ratio is 8-to-3. So those of you who like mathematics are going to have a lot of fun with this because Wenckebach block is always n+1 to n. P waves to QRSs, input to output, we'll call it. n+1 to n. So this is 8-to-3, so it's 2-level block, 4-to-3 and 2-to-1. So if you take 4:3 and 2:1, you end up with 8:3. So always be thinking for two-level block, if you see a very complex pattern, it could be two-level block with Wenckebach at one level and 2:1 block at the other level. So if you have Wenckebach plus 2:1, you end up with 8:3. This is a lot of fun to kind of work those things out. So AV dissociation and heart block are associated terms, but they are not they're not the same. They're different, but they may be associated. So I want to thank you for your attention. I know that was complex, but I went over my time by 2 minutes. Thank you.
Thank you, Dr. Martin, for an excellent deliberation. I'm sure all of you agree that he has made this complex topic look very simple to all of us. If there are any questions, feel free to ask Dr. Martin. Yeah.
So the question, I don't know if everyone could hear, has to do with left anterior hemiblock, right bundle branch block, and a prolonged PR interval, which some people will call trifascicular disease or trifascicular block. You know, that's clearly distal block. The problem with it is that the real key point in that type of conduction disturbance is, do they have symptoms or not? Because if they are asymptomatic, the progression to complete heart block is actually relatively low. It's in the neighborhood of 1% per year. Whereas in symptomatic patients, if a person has syncope and no other cause for syncope, with that ECG, I would say they need pacing. But it's really a function of, do they have symptoms or not? Thank you.
Dr. Martin? In 2-to-1 AV blocks with a narrow QRS escape rhythm, you would expect it to be a Hessian escape. But is it possible for someone to have a 2-to-1 AV block with a narrow QRS complex, and you find on EP study that the disease is actually confined to the distal conduction system? Is that possible?
So let me just try to get into the terminology a bit. Because if it's 2-to-1 conduction, they're not escape beats, they're conducted beats. When I use the term escape beats, I'm talking about beats that originate below the conduction system because of block. So if you have 2-to-1 block with a narrow QRS, could that be proximal or distal? Well, the answer is it could be either. If it's a narrow QRS, it will almost always be proximal. The reason I say almost is because you can occasionally have delay in both the right and left bundles that's simultaneous, that can give you a narrowish QRS. It's extremely unusual. So generally, if you see 2-to-1 conduction with a narrow QRS, the block will be AV nodal, not distal.
Hello, Dr. Martin? Yeah. You showed one slide where there is a patient with atrial flutter with 4:1 block, and the atrial rhythm was regular, ventricular rhythm was regular. And do you think there is a complete heart block? Because
No.
atria is listening to the ventricles there.
No. There were two ECGs with, do you want me to go back on them?
Yeah.
Because I think it's a critically important issue. Where do I find this now? I've gone off my, here we go. Okay, hold on. I showed two ECGs that looked almost the same, but were actually quite different. So the first one is atrial flutter. The atrial rhythm is regular, the ventricular rhythm is regular, but each flutter wave has a constant relationship with the subsequent QRS. So that is 4-to-1 conduction, not dissociation. They are associated. The next one I showed, and this is the critical difference, is atrial flutter in the atrium, with a regular ventricular rhythm, but the relationship between A and V is not constant. If there's conduction and they're both regular, there must be a constant relationship. If the relationship is not constant, it cannot be conducted. So now I'm going to look here. I see this flutter wave, and I compare it to this QRS. And now I look here, and it's different. So once I've established that both the atrial and ventricular rhythms are regular, I look to see if the relationship between each atrial activation and each ventricular activation is constant. If it is not constant, then they are independent. So this is AV dissociated. This rhythm, this ventricular rhythm, is not conducted. That's the difference between this and the previous ECG, which is conducted. Does that answer your question?
Thank you, sir. I now request Dr. H Srinivas to felicitate our speaker with Dr. Martin Green. And I request Dr. Martin Green to hand over the certificates to